Susie Keller, how are you?
I'm doing great. Thanks for having me, Matt.
Thank you for being here. You are the CEO, the C-suite lady for Idaho Medical Association. So
Correct.
you represent medical professionals and what is good and bad and the other for them across the state of Idaho, and then communicate that. You're like an upside down funnel where you aggregate information from the medical establishment. People say this is bad or this is bad or this is a problem or this is going really, really well. We need to keep this. It all comes to you, and you at the IMA then are able to communicate with the force of knowledge from across the state what is important or relevant to our medical professionals, to our state government.
That is absolutely correct. So we represent physicians. We're the largest organization representing physicians across the state of Idaho in all specialties and all practice settings. And we represent the vast majority of physicians. And so we like to say we are the voice of medicine in Idaho.
God bless it. Now, medicine in Idaho has a lot of pieces. There are a lot of challenges. And, I think some, like women's reproductive care, really suck a lot of oxygen out of the room because people are very, very, fired up about it, which again, they should be. I think this is a really important conversation to have. But there are other things going on in the medical establishment, like being able to staff our hospitals, like being able to staff our clinics, like being able to aggregate enough successful and competent medical school graduates and things of that nature. Nursing is obviously one of those things. Everybody knows we have like a mass shortage of nurses. There are things going on with this. Talk to me about what we're doing with staffing hospitals and medical establishments.
Absolutely. So the last time I was talking about the challenge of the healthcare workforce in Idaho and what's driving those challenges. But on the flip side, our state has been doing some really awesome things to help grow our physician workforce, and we've been doing it for quite a while. So I just wanted to highlight some of those things and thank the state of Idaho, the governor and the legislature for their support of this program that I'm going to talk about that has had wide bipartisan support for years. So in 2018, the IMA was part of a group of medical professionals leading medical education and residency training that came up with this plan to grow our training opportunities in the state of Idaho. It was the 10-year plan to expand graduate medical education, otherwise known as GME. What is that? When I talk about training physicians, I like to think about it in terms of a pipeline. So we start here with K through 12 and the state of Idaho putting their resources there. Then folks go and get their undergraduate degree at a college or university. And then that's when they apply to medical school. So we have programs here in the state of Idaho through the University of Washington WWAMI program, the University of Utah, and we have the Idaho College of Osteopathic Medicine. So we have a very robust part of the pipeline producing medical students. Then after you graduate from medical school, you need to do a residency training. A residency helps a physician determine what kind of specialty they're going to have. Are they going to be a family doc? Are they going to be a psychiatrist? Are they going to be an OBGYN, a surgeon, etc.? So doing residency training helps determine that. That time period ranges from 3 to 5 surgical subspecialties, sometimes up to 8 to 10 years.
Wow, I didn't know that residency is that like super specialized?
I think super specialized. Okay. In the state of Idaho, what I want to talk about today is that residency training pipeline. Of course, after residency training, we have to have a good practice environment for folks to come back here, loan repayment, good practice environment, et cetera, et cetera. So that's the other part of the pipeline where Idaho's also done some cool stuff on loan repayment, but I mainly want to talk about the residency training or GME and why it's so important for us to continue this 10-year plan to expand those positions. And it has to do with numbers. So right now, with our medical school programs, Idaho is graduating about 200 medical students per year, which is awesome. In terms of residency training positions for them, we're just under 100.
Okay, so over 100 people, even if they want to stay here for residency, over 100 people, over 50% of the people who are graduating from medical school do not have a place to engage in residency.
That is correct.
Okay.
And it's not just a numbers game, it's a specialty game too, because We have in Idaho residency training for family medicine, for internal medicine, and for psychiatry. And a new program that just started up a couple years ago is pediatrics. So very primary care and mental health focused, which is fantastic. But if somebody wants to become a general surgeon, an OBGYN, a rheumatologist, they do have to go out of state to get that residency training. And then we hope they will come back and practice here.
Man, I feel like an idiot. I have been telling people whenever medical stuff comes up, I'm like, well, one of the problems is Idaho doesn't have enough medical schools, right? Like we need these medical schools, which may be true. But the more important piece is like, we don't have enough spots to capture our existing medical students. So it's I mean, like, yeah, fine, the medical school, fine. But like, that's irrelevant until we can capture people after medical school and offer them residencies and offer them a wide breadth of specialties that they want to engage in.
Yes, man. That is correct. And
I miss the mark so frequently on things. And this is just thank you, God.
I'm here to help.
God bless it.
So yes, you hit the nail on the head. And residency training is important for two reasons. Number one, while these physicians in training are learning and getting mentored in these accredited programs that are standardized across the United States, while they're getting trained, they're also seeing patients. So they are part of our healthcare workforce while they're doing their residency training in the state of Idaho. So that's pretty cool. The other thing is that in Idaho, this is one of the things that we're really good at. We lead the country. I want to say we're in the top 5 states for retaining residents that practice here. So if you do a residency training program here in Idaho, you are more than likely to stay and practice here. And so this is one of our best recruitment tools, it turns out. And in fact, I want to say the latest numbers show that Idaho is retaining over a 10-year period, 67% of the residents that we train here, which is phenomenal. So the state of Idaho does provide a third of the cost to support residency training, but they get a tremendous return on investment where there's a physician in a local community hiring a staff, taking care of patients, et cetera, et cetera.
Okay, so question for you. For the people that go outside of the state to do residencies elsewhere, like what is the number, like if you pick another state like Wyoming or wherever, what is the residency retention in those states? Is it, and again,
I have a piece of paper that I can tell you, pick a state. I have the rankings right
Let's
here.
go Utah.
Utah, 53.5%.
Okay. So Idaho, if we just take Idaho and Utah, beats the snot out of Utah to the tune of like, I don't know, it's like 20% higher than Utah. We can retain more people if we just get them here and they like see the beauty and awesome of Idaho, whatever it might be. And that could be the working environment. It could be, the state itself. We just need more of these spots. It's like, listen, just get them here and we'll grab them and they won't leave.
Exactly. And so then I'll touch on the practice environment a little bit. So to get them to stay after training or to get them back to Idaho if they've gone out of state for residency training, what do we have for loan repayment? Going through medical education training is tremendously expensive. I sit on the board of an entity called the Rural Physician Incentive Program. It's basically loan repayment. And folks are coming out of training with $200,000 to $300,000 of educational debt. So we have a program, if they practice in a primary care specialty in a rural and underserved community, we provide loan repayment for them of up to $100,000 over a 4-year period. So $25,000 for each year that they stay in practice. And that program has an amazing 90% retention rate. So that's another thing we're doing really well at.
So once you get them into once you get them to Salmon or Chalice or Blackfoot, wherever, you get them there, you help, they engage in the community. And of course, you help repay $100,000 worth of their debt. 9 times out of 10, they're like, I'm not leaving. I'm staying here.
Exactly.
That's beautiful.
It's really cool. And they become, some of them have Idaho ties. Some of them grew up in a rural community in another state, but you're exactly right, which also speaks to practice environment and what are important things. Obviously, our K through 12 public school system in Idaho is important. physicians value education. And so having good schools in our local communities for those families that value that, that's a good thing. Are there job and career opportunities? A lot of physician spouses are professionals themselves, and do they have opportunities that they can take advantage of in different communities? So there's a lot of things we can do to make ourselves a great state for physicians to practice.
Listen, I don't know how this works, but how do we get more residency programs? That seems to be the bottleneck, right?
It is a bit of a bottleneck, but fortunately, really smart people in the medical education and residency training world came together with the Idaho Medical Association, the Idaho Hospital Association, and others, and created this 10-year plan back in 2018, submitted it to the Idaho State Board of Education. They gave their blessing on it. And ever since then, we have presented this plan that says, here's how we can strategically and systematically grow residency training in the state of Idaho. And state of Idaho, can you help foot a third of the cost of training these folks? So the program itself generates a third of their revenue through either grants or patient visits. The sponsoring entity of the residency training program supports a third of the cost, and then we're asking the state of Idaho to pick up a third of the cost, which right now is $60,000 per year per resident. So, for instance, the legislature, fortunately and thankfully, has been approving the first 7 years of the plan. So we have gone from when we started in 2018, we had 134 residents, and now we have 264. So we've almost doubled.
That's in the last 7-8 years?
Correct.
That's fantastic.
And the number of programs, we've gone from 9 to 16, and we added that new specialty of pediatrics. So for the 8th year of the plan, we're asking for state funding for 14 new resident positions, and then there's another 5 that are coming online that are fully federally funded, but 19 new residency positions in the state of Idaho for the next fiscal year.
Okay, I am constantly taken by Idaho from identifying problems in a pragmatic nature and being like, okay, how do we fix this? It's like, roll up your sleeves, man. Here we go. We're going to have to do this. We're going to have to do this. And I've been, since you and I first met, I've been really concerned, and I was fortunate to interview Representative Vanderwoude, who's, at least at the time was the chair of the Health and Welfare. And he was saying yeah, we have this problem. We have education problems. We have funding problems. We have all of these problems. And it's yeah, but we're knocking it down. It's not a quick fix. It's not a 1-year solution. It's a grind through over the next 20 years. And when my kids, my youngest is 8, right? And when he's, perhaps getting married and starting a family, it's yeah, we're going to have a lot more options for the state of Idaho. And, Idaho really takes it on the chin for a lot of reasons in the medical field. But it's yeah, look, we're trying to solve this, and it's not easy. We have a lot of populations in very widely dispersed areas and very rural areas that present all kinds of problems for the medical establishment. It's God bless them, man. We're banging it out.
Yeah. And this is one, like I said, you can tell I'm excited about it, but it is truly this private-public partnership that came together, and it's been really cool to see this sense of collaboration amongst the different programs and leaders in different parts of the state coming together and saying, no, we want to do this, and we want to see this growth. And shout out to Representative Vanderwoude, because he is somebody who has been very supportive of that Rural Physician Incentive Program, also known as RPIP, the loan repayment. He is somebody that helped lead the charge on bringing more state dollars into that program, which means more loan repayment opportunities for rural docs.
God, I got to get him back on.
Yeah.
I really appreciated him. He was a cool guy to talk to. Okay, so we're addressing residency issues, medical school issues, right? We're retaining more people. We're paying back a portion of medical costs for people that engage in our rural communities, all great stuff. Is there anything else that we're hunting? And I know there are a lot of things. I actually have a lot of questions about Medicaid. We're not going to touch on them today because we don't have enough time.
Okay.
But I have questions about that as well. I had Representative Rubel on, who was talking about, we were talking about property taxes as they relate to commercial versus residential, and then of course property taxes as commercial property taxes as they relate to hospitals and the increased cost of things. If Medicaid was to be, expansion was to be repealed, like how that plays out. And at some point, I think she was like, well, at some point, like physicians kind of foot the bill for services that they're offering then engaging. And it's like, okay, so we're saying that we're going to ask physicians to come here and then have the privilege to not get paid for work they're doing. Like that's a really rough pill to swallow. So we'll have to talk about that another day. But Is there any, I know today's a working day. I pulled you out of the Capitol to have this conversation. Is there anything else you want to hit on today?
I guess I would say we're doing a really good job on this. We're medical education, medical school part of the pipeline, very robust. We're working on this part of the pipeline. But our state is growing so fast that Idaho is still, we bounce around the bottom number of states. And right now we're at number 50 in physician to population ratio. So we're doing all these good things, but we need to keep at it and looking at those other opportunities. And again, lots we can do in the practice environment part of things, probably another conversation for another day, but Medicaid expansion is part of that. The practice of medicine being made illegal in some circumstances is part of that. But there's also some other things that I think are well-intentioned trying to hit at this workforce problem that we have that in the end probably aren't as helpful as they are meant to be. And one example is some legislation that was recently introduced that actually allows medical school graduates to circumvent the residency process and do a 3-year apprenticeship and then get licensed by the Idaho Board of Medicine as a general practitioner. And so that one's a bit of a concern for many reasons. Did you have a question?
Okay. So as it stands right now in Idaho, you got to go to medical school, then you got to do a residency. And the residencies are not just like flavor of the day. Residencies are like, these are really robust, specifically designed things to train doctors so that when I go see a doctor, I have, wasn't it Providence or I have confidence. There it is. I have confidence that's like, okay, this doctor has been whatever.
Yes.
And this bill's like, hey, that whole thing about residency after medical school where like you go through these really rigorous things, we're just going to replace that with you like shadowing a doctor for like 3 years. That doesn't actually enhance my confidence in the medical establishment.
Right. So there are quality concerns, but the bigger problem is that it's not a workforce solution because insurance companies and hospitals will not credential these folks. So, and this is not just an Idaho thing. This is across the country. In order to be eligible for credentialing, you have to be eligible for board certification, which is national sort of certification. If you haven't done a residency program, you are not eligible to be board certified. Therefore, this provider can't be credentialed by a hospital and cannot be credentialed by an insurance company. So that takes out of their realm the vast number of Idaho patients that they would be able to treat. So they're not going to be making a big impact. And there have been a handful of other states that have tried this, and there's just no uptake on it because of the limitations. Like it's very career limiting for those folks that seek to apply for this license. And it's a little bit confusing. It's called an assistant physician license. But just something that's been proposed.
Don't we already have a physician's assistant?
Yes.
We have a PA. You're like, no. We're going from PA to AP. It's going to be wild.
It's a little confusing. In my opinion, a little unfortunate naming because it is confusing.
If I may ask, and I'm sorry, I know I interrupted you. Okay, like the whole nature of this is that we have a physician shortage, and physicians exist in the ecosystem of hospitals, insurance companies, like certifications, quality control. So like this person, an assistant physician, were they to get this, they would have to exist outside of a hospital network, outside of an insurance reimbursement network. And yeah, maybe there's a place for people, like I understand there's a place for like free functional clinics, medicines or some things like that. But like how that first off, you'd be footing the bill. Like, we worry about getting enough people medical insurance in the first place. Cause like, if you don't have medical insurance, it's a really rough road to be able to afford medical care. Right. And yeah, there's a world where people engage in their health care and their health in general that's outside of the insurance. That's fine. But like, the crisis we have is not, the limitation we have is not people that are existing outside of the established medical system. The limitation we're experiencing is people that can function inside the medical establishment. So it's like, fine, maybe there's a world on a market like out here where you have all these alternate medicines and things. Fine, I don't care about that. But if we're trying to address the problem of within the hospital established Western medicine ecosystem, this doesn't address anything within that ecosystem. It has to exist on the outside.
Right. These individuals would probably have trouble. Well, they can't get credentialed at a hospital, so they can't treat anybody there. And they'd probably have trouble getting hired at a medical clinic that accepts private insurance or even Medicaid, because they may not be able to get credentialed and bill for it. So if somebody wants to build their career around just providing free medical care, go for it.
Yeah, but Patch Adams all day long. Go Robin Williams.
Yeah. So while that is a noble pursuit, I don't think that's what people are seeking to do. And there are many other avenues to be able to volunteer and take care of uninsured patients, et cetera.
Yeah. And at the very least, just say, hey, look, I hear that there's a problem. There's a crisis of limited people to employ within this hospital association. That's a problem for another day. Right now, what I'm trying to solve is like the lack of people that are offering free medical care out here outside of that system. But like, and that's a fine thing too. Just don't conflate the two. Don't say, hey, look, this thing is only good for people that are offering free care outside of a hospital, and we're going to use that to address the hospital. It's like, that doesn't fly.
Right. And we have this part of the pipeline that is robust, that needs more resources to grow it. So let's create more access to that instead of just skipping over it. Because that doesn't benefit the individual, and it turns out it doesn't really benefit Idaho patients either.
Good Lord. Susie Keller, I really appreciate you. Thank you for coming in today. Let's get another one on the calendar, because I got a lot more questions I want to ask you, and I know our time is limited today because you're, hustling around. Anything else just for today?
Not for today. Look forward to future conversations.
Awesome. Thank you for coming today.
Thank you.